Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, it's great to have you all with us on this Sunday night, whatever time zone you are in. You are in the fourth virtual heart failure group meeting of the Emirate Cardiac Society of this year. The theme we've chosen is cardiomyopathy. This, for the first time, we're doing this in jointly with the Russian Cardiac Society, which is a really great thing to have. Reassure you, we'll have a fantastic talks with a great team, two speakers, which I will be introducing shortly after I introduce the first speaker. And then so each talk will be 20 minutes. After that, I've got a symposium talk, which I'll deliver at the end, another 20 minutes, and the question at the end. So all the question will be at the end. Your question, you cannot join by voice, so please write all your questions as we go in the chat box. We'll collect them and we'll answer them at the end. I also to remind you, at the end, there will be a link in the chat box for you to give a feedback in order to get your CMEs. So without further ado, I will introduce our first great speaker, my really good colleague, Dr. Hussam Ghalib, who works in the UAE, need no introduction. He's a consultant cardiologist, advanced heart failure and transplant in the Cleveland Clinic, Abu Dhabi. He's actually the director of the cardiomyopathy clinic, for those who don't know, in Cleveland Clinic, Abu Dhabi. He had his medical degree from Johns Hopkins University School of Medicine, Baltimore, Maryland, USA, and he did his advanced heart failure training in the University of California, Los Angeles Medical Center. And today, with his background, he'll be the right man to talk to us about really, setting up HOCM or Hypertrophic Cardiomyopathy Center of Excellence. What are the goals, why we do it, and what's the requirement? Dr. Ghalib, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Muhammad, for the kind introduction and for the involvement in this wonderful symposium and seminar. I look forward to learning from you and Dr. Anna in this learning. So briefly, I was tasked by Dr. Al-Harari to talk about hypertrophic cardiomyopathy, and I will try and be brief. Just out of interest, this is what artificial intelligence thinks a hypertrophic heart looks like and what a multidisciplinary team taking care of a hypertrophied heart looks like. So it shows you that artificial intelligence has a long way to go. I have no financial disclosure as relates to this topic. Briefly, we will have a case presentation. We'll go over hypertrophic cardiomyopathy as a condition, go into some management options and how we decide to treat certain etiologies and manifestations, and then delve into what a hypertrophic cardiomyopathy center of excellence means and what their requirements and goals are, and then come up with some take-home messages. So in this case, it was a 54-year-old male who came in with exertional dyspnea that was getting really out of hand. No prior syncope. He's got stable vital signs and has a harsh pansystolic murmur, which did not radiate to the carotids. And these are his echocardiograms showing significant systolic anterior motion, hypertrophy of the basal septum, and as you see there's mitral regurgitation as well. We performed a Valsalva maneuver, which showed the classic spade-shaped or dagger-shaped CW signal, indicating a significant LVOT dynamic gradient of 162 millimeters of mercury. And you can see here that we confirmed that on color flow as well. We then proceeded to perform a cardiac MRI, and what you can see there is that the hypertrophy isn't really just limited to the septum. Also the posterior wall is involved, and you can see the clear systolic anterior motion happening in systole here as well. So hypertrophic cardiomyopathy is one of the two, or is the most common inherited cardiac condition. If you include patients who were diagnosed by genetic testing but don't have a positive phenotype, it's in every 1 in every 250 patients. So it's pretty common. And the main part of the pathophysiology is these abnormalities in the interaction between the actin and myosin heads, showing that they're more remain in the active stage, and we will get to that as we talk about therapeutics later. And most of the proteins involved are those involved in the thick myofilament proteins, in the myosin heavy binding protein C and the myosin heavy protein here. But also there are mutations in the thin myofilament, in the Z discs, as well as in the M-line proteins as well. So very heterogeneous genetic makeup of this condition. Most of the patients, about 70%, have obstruction, which is this dynamic LVOT obstruction. As we note here originally, we used to see these on the M mode echocardiograms. This is how it would be identified on invasive cath lab, as well as on regular 2D echocardiogram, showing the pretty significant systolic anterior motion noted here on this echocardiogram. So if you have a gradient more than 30 millimeters at rest, you have symptoms of dyspnea or exertional dyspnea, then you're classified as an obstructive patient. If you don't have that on echo, then we go the extra mile of making sure that we do an exercise echo to look if this gradient can be brought out by exercise. If not, then we do a Valsalva maneuver or make them inhale amyl nitrate. And then in the cath lab, we can also induce a positive ionotropy to try and get out the gradient. And why is it important to discern this obstruction? We'll get into that in a little bit. Now, there's the remaining 30% of hypertrophic cardiomyopathy that do not have this LVOT classic dynamic obstruction and thickening of the septum. You can have involvement of the RV. You can have the apical variant, which is very common here in the UAE, with associated aneurysms. You can have abnormal papillary muscle connection, and that being the main manifestation. You can have elongated chordae. You can have multiple papillary muscles that are all hypertrophied. And then you can have crypts form within the hypertrophied. So these are all considered to be subtypes of HCM that are confirmed in genetic testing. Now back to obstruction. Why is obstruction important? Well, if you have obstruction, your freedom from death is really lower. So that means your prognosis is worse than patients who don't have obstruction. And that's why it becomes very important to try and elucidate this obstruction or this elevated gradient on echocardiogram, whether at resting state or with exercise. Now, beta blockers are really the mainstay and the first therapy that we try and initiate in these patients to try and improve their LVOT gradient. And interestingly, they were only studied in 2021 in this RCT, showing that beta blockers really do reduce the LVOT gradient and reduce the exertional dyspnea, but they didn't really have an effect on your VO2 max or exertional capacity. Disopyramide is another agent. This was studied earlier back in 1988, and it really showed the same thing. It increased the exercise duration, but it didn't really have any change on the patient's sort of prognosis. You can reduce the gradient from 60s to about 5, and they get to exercise more, but there's no change in prognosis. And calcium channel blockers, which tend to be the things we try second after beta blockers. This is the original trial in 1993, showing that in this case, the patients felt better, but without their exertional capacity increasing. So it showed you that these were all not very selective medications for obstruction, but that's what we were left with, and that's what we had to try back then. Interestingly, now we have these selective cardiac myosin inhibitors, which we will hear about today in the symposium at the end. The first one was mavacamten, and we will delve into how that works in the symposium. And the second one was aficamten, and I'll briefly mention that here, is that this is a reversible binder to the cardiac myosin, decreasing the number of cross bridges that are active. So remember that first slide we showed how in the disease state, there's an increased number of active engagement of the actin and myosin, and this is sort of resulting in more relaxation. Aficamten was first studied in a phase 2 trial called the Redwood HCM, and this really showed that a lot of the patients had a change or drop in their NYHA functional class during the 12 weeks of this trial compared to placebo. This was just a safety trial performed in North America and Europe. And then subsequently, there was a phase 3 double-blinded trial called the Sequoia HCM in patients with symptomatic hypertrophic obstructive cardiomyopathy. And this was comparison to placebo, but these patients were also on beta blockers and disopyramide or calcium channel blockers. The dose was adjusted by echo, looking at the gradient. And this was performed really in 14 countries throughout the globe, including Asia. And, just like we'll hear about it with mavacamten later, there was an improvement in the exertional capacity as measured by the mean peak oxygen uptake on the patients who are on aficamten compared to placebo. And then when you look at the gradient, the LVOT gradient, it dropped with aficamten. And then during the washout period, it came back to the baseline again, proving that this is a reversible binder. Interesting, in heart failure, we'll always look at the improvement in symptoms as well. And you can see here an improvement in the Kansas City cardiomyopathy questionnaire with aficamten compared to placebo, and then it drops back down again during the washout period. Like I said, we'll talk about mavacamten in the symposium, but it's the same idea and the same actually results. An improvement in the Kansas City cardiomyopathy questionnaire. The patients had a reduction in the number of patients with NYHA functional class 3 and more patients with functional class 1 or drop in class 1 with long follow-up. As you can see here, this was a robust and persistent improvement in their Kansas City cardiomyopathy questionnaire scores. The LVOT gradient dropped significantly and remained there with Valsalva as well. There was a small drop in LVF, but it was not clinically significant in most of the cases. And in the real world, you see these are some data showing that when utilized outside of these randomized clinical trials, patients still had a drop in their LVOT gradient and improvement in their NYHA functional class. We will get into this later as well. There's a very specific risk evaluation and mitigation strategy of how we initiate this medication and maintain it. Now, what happens if you are on these therapies and you don't improve, or if you don't have access to these therapies and you're significantly limited in your daily living? Well, septal reduction therapies in terms of alcohol, septal ablation, or septal myectomy are really your next options. As you can see here, this is performed in the catheterization lab with the aid of echocardiography as well, where there's selective engagement of the septal branch of the LAD, where the thickening is noted, and then through small and incremental installations of alcohol, you result in a controlled myocardial necrosis in that region and resulting in a reduction in the hypertrophy. And here, this is the septal myectomy performed through the aortic approach to also incrementally shave off areas of the septum to result in relief of the obstruction. Now, how do these invasive septal reduction therapies compare to placebo or medical therapy? This is a meta-analysis showing that there is an improvement in the exercise capacity in all these trials up to 2020 involving these patients with septal reduction therapy. So they do result in a benefit. There's also a similar reduction in the NYHA functional class, as well as the gradient coming down. When you compare the two, septal myectomy versus alcohol septal ablation, the pacemaker rate tends to be higher with the alcohol septal ablation, but the initial mortality rate needs to be higher with the surgery. So the classical thinking is if a patient is thought to have a low surgical risk, potentially young patient, no comorbidities, then the surgery would be the preferred route. If a patient has a lot of comorbidities and or already has a pacemaker, then the alcohol septal ablation is pursued. This is just another meta-analysis now looking at the all-cause mortality when adjusted for comorbidities, showing that there is a slight sort of statistically significant, but there's a slight trend towards favoring septal myectomy in all comers, showing that if these surgeries are done at a center of excellence and in carefully selected patients, it really should be the gold standard. Keep in mind these are meta-analyses of retrospective data as opposed to randomized controlled trials. So what is the benchmark? If you're a center that's providing these surgeries based on American guidelines just published earlier this year, you need to have such expertise that you can provide less than 1% mortality within 30 days, whether you're performing the myectomy or the alcohol septal ablation. And as you can see here, your outcomes need to be pristine, improvement in white shame in more than 90% of your patients, improvement in the gradient by more, dropping it less than 50 millimeters in more than 90% of the patients, not having a lot of mitral regurgitation. So pretty stringent numbers, just like the numbers you would see for, per se, mitral valve repair, because these tend to be young patients. So briefly, we'll talk about mavacamten and how it affected these septal reduction therapies. This was the VALOR HCM RCT, and I'm sure Dr. Al-Harari will go into this later as well. But there was a decrease in the number of patients requiring to end up receiving these septal reduction therapies when they were put on mavacamten during this trial. So this is potentially a surgery or intervention preventing medication. This was very exciting. Now, moving on away from obstruction, talking about the other mode of manifestation and the other important clinical phenotype in HCM, which is sudden cardiac death. Hypertrophic cardiomyopathy is the #1 cause of sudden cardiac death among athletes in the USA and also noted worldwide. And of all the sudden cardiac death episodes within athletes, 36% or a third were related to HCM. How do we predict sudden cardiac death? Well, very crudely is what I would say. There are two models that you can plug in and to predict this. There's the American and the European models. The European model is based on multi-regression analysis, and the American model is used on historical clinical data. There are some shared risk factors such as family history of sudden cardiac death or unexplained syncope, or having the LV wall thickness more than 3 centimeters. But then that's where they digress. Here in the European, there's a measurement of the left atrial diameter, and the gradient itself manifests itself. Importantly, the European model gives you out a number, and if your 5-year risk is more than 6%, then you're considered to be high risk, and an ICD should be considered. If you're between 4 and 6%, then an ICD may be considered, and patient-physician discussion should be the cornerstone of decision-making. And if you're less than 4%, then ICD is generally not indicated in these cases. The American risk prediction actually got updated through the years. And now if a patient has late gadolinium enhancement on MRI of more than 15%, specifically in the regions of hypertrophy, or if the LVEF is less than 50%, or if the patient has the apical variant of hypertrophic cardiomyopathy and there's an apical aneurysm, these are considered to be high-risk features, and an ICD should be considered. Furthermore, there are specific subtypes of HCM where the reverse curvature or the sigmoid septum is noted. These also have a high risk of sudden cardiac death. And then we started getting into the more longitudinal data showing that the elderly, if somebody is above 60 years, they're probably not going to have a high risk of sudden cardiac death. And if a patient doesn't have any mutation genetic testing as well. This was a very interesting article that I recommend people interested in the field to look at, showing how we have moved really from conventional risk factors to this multi-parametric imaging model, looking at late gadolinium enhancement, looking at strain on echocardiogram, looking at the left atrial size, and how dilated your ventricle is in terms of predicting your sudden cardiac death. We now know that modern therapy with earlier detection, genetic testing, improved echocardiography, in medications and how they can modify or reduce the risk of sudden cardiac death, as well as these septal reduction therapies. These are all thought to be therapies that modify the phenotype and may actually reduce the risk of sudden cardiac death. And this was actually neatly shown that the global rates of sudden cardiac death from hypertrophic cardiomyopathy have really been decreasing through the years. So if you compare pre-2010 to after 2010, there's a rapid drop in North America, in Europe, in the United Kingdom, and in Asia as well. And the thought process is we are diagnosing more patients with HCM, we're managing them earlier, we're having these discussions early, and therefore we are actually making a dent in the sudden cardiac death rates. So what is the hypertrophic cardiomyopathy heart team? First coined in 2020 by this team. And they're really, the HCM team is a team that has specific expertise in hypertrophic cardiomyopathy and can play a critical role in several things. The first of which is actually confirming the diagnosis of HCM. You get patients referred in. This is an article from last year in a referral center for HCM, where 1 out of 6 patients who were sent over for HCM care actually got reclassified as non-HCM, either as, in this case, this is a case that was reclassified as amyloidosis, showing the significant LGE and the concentric thickness and the biatrial enlargement, or actually on MRI confirming that there isn't really significant hypertrophy and that this isn't really HCM after all. So this can be a huge relief for the patients and actually may lead to improved therapies for other conditions. So the first role of the HCM team is to confirm the diagnosis. Secondly, this is data also from last year showing that patients who come and see an HCM center and then go and get their care away from that are actually at a higher risk of complications. So they had more ventricular arrhythmic events, they had more hospitalizations, they ended up requiring more surgeries, and their symptoms were worse. So potentially the Center of Excellence can better take care of these patients. And I briefly mentioned the earlier guidelines, of the American guidelines on this, published earlier this year, showing that in patients who are being considered for these septal reduction therapies, they really should be cared for and seen in a center of excellence that has the expertise in performing these surgeries and has the stringent quality criteria for these patients. And then when these patients are going through specific disease-related complications, they should be cared for there as well, such as pregnancy for HCM, surgeries, non-cardiac surgeries for these patients, and so on and so forth. The same article shows some of the differences between a primary HCM center and a comprehensive HCM center, showing that the main differences relate to septal reduction therapy. So, the use of echocardiography and alcohol septal ablation, as well as invasive evaluation of these gradients for these patients. Next becomes the decision about ICD decision-making for patients who are younger, so children and adolescents should really be deferred to a center of excellence. And then if and when these patients progress in their disease to having advanced heart failure, they should be seen in advanced centers as well. Next becomes the issue of exercise and how to risk stratify the risk of exercise-induced sudden cardiac death. And like I said, in pregnancy. So just the nuances and the specifics about care for these patients that outside of the LVOT gradient management with medications. So real quick, what happened in this patient? So we diagnosed them as hypertrophic obstructive cardiomyopathy with partial subaortic membrane and systolic anterior motion and moderate MR, was deemed to be of low risk of sudden cardiac death as per both criteria, the American and the European. And the patient safely underwent septal myectomy with complete resolution of their symptoms. These are just some still frames of their echocardiography showing no significant gradient. Real quick, I mentioned advanced heart failure in these patients. So about 5% of patients with hypertrophic cardiomyopathy will develop advanced heart failure to the point that they would have a very low 6-month prognosis. or bad prognosis, and they don't have an ejection fraction below 25%. They can have ejection fraction below 45 or 40% and have advanced features. These patients are a candidate for heart transplantation or LVAD placement. The issues with LVAD become the thick ventricle and the small ventricle, and the issues with low flow or suction events. But those can be managed with device management. And obviously, heart transplantation also has challenges in these patients because they frequently have pulmonary hypertension. Long-term patients with hypertrophic cardiomyopathy perform better and have a better outcome than patients with ischemic cardiomyopathy and non-ischemic cardiomyopathy. So in summary, the roles of a hypertrophic cardiomyopathy center of excellence start with confirming or refuting the diagnosis of HCM. Once the diagnosis has been made, you come up with a treatment plan for their obstruction if they do have it, including starting with the typical agents and then upgrading to these cardiac myosin inhibitors. And for patients who don't respond, they should be considered for septal reduction therapies. Sudden cardiac death risk prediction and prevention is a cornerstone of our management. And then for those patients who really have advanced heart failure, providing them with advanced heart failure options. With that, I thank you, and I pass it back to Dr. Al-Harari.
Thanks a lot, Dr. Sam Ghalib. That was really great. Learning every second. Fantastic. Excellent. We'll leave the question to the end, as we said. And now it's my pleasure to introduce the second speaker. We said earlier on, this meeting is done jointly with the Russian Cardiac Society and represented by Dr. Anna Kostereva. She's a consultant cardiologist. She's the director of the Institute of Molecular Biology and Genetic in Ilmazov Medical Research Center, St. Petersburg, Russia. She's associate professor in Oslo University in Norway. She's associate professor in Bavio Medical University and Almazov Research Center in Russia. She is very extensive research and publication, particularly in the genetics of cardiology. That's her interest. And she's no doubt the right person to give us this talk titled Rare Forms of Cardiomyopathies in the Light of the New Classification, Secondary Syndromic or Phenotypes. Dr. Kostereva, the floor is yours. Welcome.
Thank you very much, Dr. Harari, and thank you for inviting me to speak on this meeting. It's a great pleasure for me. And I will continue now the topic on cardiomyopathies with a special focus on what we call secondary or syndromic forms or phenocopies. And I would like to start now first from the classification, which has been changed several times during last several years. And we all know very well the classification of European Society of Cardiology, which is here on the bottom, with the classical morphological forms of cardiomyopathies: hypertrophic, dilated, arrhythmogenic, restrictive, and unclassified, which doesn't exist anymore. But along with that, we used to have also American classification, which had a special form of secondary cardiomyopathies. And actually, in between these two classifications, we had some troubles to put into the right place the forms of cardiomyopathies, which we see in a frame of syndromic disorders or secondary disorders combined with the neuromuscular system, for example, or some other syndromic disorders. If we now look on the new classification, which has been proposed by European Society of Cardiology the last year, we see first that we have a transformation of the morphological forms. So we don't have any more form which was called unclassified, which actually mainly was targeted to left ventricular non-compaction, and have instead of that a new form of non-dilated left ventricle, But anyhow, right in this classification, we do not have the proper place for the secondary or syndromic forms. And according to European classification, all these forms are still can be seen in frame of either familial and genetics or non-familial and non-genetics. And it doesn't matter whether it is a part of big syndrome or it is a separate just cardiological disorders. And what in this classification we can see the definition that syndromic or metabolic disorders are those which are combined with different parts, mainly with the rasopathies, mitochondrial pump diseases, and some other disorders. But what is very important in this classification, we can read that these diseases are beyond the scope of the guidelines, and to provide the detailed review and recommendations for this disorder, we have to go deeper for the proper and specific guidelines regarding the specific phenotype, which is a very difficult clinical task, because to go to the clinical phenotype, you must know this clinical phenotype. And that's why today we mainly talk on rasopathies and Danon disorders, Fabry, and some neuromuscular disorders, which we can often see in frame of syndromic and secondary forms of cardiomyopathies. They're quite common. To talk for syndromic or secondary forms, called whatever you like, is important not only because of the diagnostic purpose, because we know all the genetic reasons for cardiomyopathies, and in cardiology we are quite happy to have a lot of guidelines in terms of genetic counseling since 2010. But apart from diagnosis, we can always use this information not only for risk and prognosis, as has been demonstrating recently, but also now we can use this information for the therapy. And new specific therapies coming not only for sarcomeric and classical forms, as for example with mavacamten in hypertrophic cardiomyopathy. It also comes for some specific disorders among secondary and syndromic forms of cardiomyopathies. And to diagnose these patients is very, very important. I would like to start first from the combination of cardiomyopathies and neuromuscular disorders, because muscle cells, both in skeletal muscles and in heart, have a lot of common structures in between. First, of course, this is sarcolemmal structures with a dystrophin complex. Then it is a lot of proteins in nuclear envelope, which is called envelopathies, and includes lamins and some other proteins. We can also look for mitochondrial disorders, but this is not in the scope of our talk, because this is mainly pediatric practice and quite common neurological complications. Of course, we can talk about Z-line associated proteins and also about some iron current channels, because all these genes can lead not for primary cardiomyopathies, but also for the syndromic forms, because of common expression of these proteins, both in skeletal and in cardiac muscle. And to illustrate this, I would like to mention that the first genetics of dilated cardiomyopathy was demonstrated due to the mutation in dystrophin gene, long in 1993, which is very well known neuromuscular disorder. So the common history of dilated hypertrophic and restrictive cardiomyopathies and neuromuscular disorders is very long. And the most common form of these combined phenotypes are nuclear envelopathies. A lot of proteins we can find within the nuclear envelope, and they can lead both to cardiac phenotype, to muscle phenotype, and to the combination of cardiac muscle phenotype. And the most common gene is here lamin gene, which is one of the very often seen in case of dilated cardiomyopathies, for example. And to illustrate this, I would like to start with a clinical example on a woman who 35 years old, which presented with dilated cardiomyopathies. This is the most common form for lamin mutation. But apart from dilated, she had a mandibular dysplasia. You can see it on the picture. She had also severe muscle atrophies, you can see on the hands and on the leg, and almost normal CK. Why is it important to know? because about 8% of all our patients with a heart transplantation are patients with laminopathies. And we always have to consider that these patients are very prone to progeroid type of disorders, which means early atherosclerosis and very low mass, which can limit the heart transplantation. And there currently, we do not have the proper guidelines for heart transplantation in lamin patients in frame of neuromuscle phenotype and in frame, for example, of neuromuscle disorders, which is always very important to consider in a clinical picture. Another clinical example is the nuclear envelope genes in pediatric patients with AV blocks, for example. Here I would like to demonstrate one of our case series where we simply chosen several patients in pediatric practice who started from AV blocks and different types of cardiac conduction disorders. And to go further, after they have been genetically diagnosed, we realize that most of them have any kind of nucleopathies and envelopathies along with Emerin gene mutations and lamin gene mutations. Why is it important? It's important because it leaves the very important decision on ICD and pacemaker implantation, on heart transplantation, which can often be in pediatric patients, which is not quite clear and quite simple. And in all muscle disorders, we can always think about respiratory function, which makes sense in terms of rehabilitation for this patient. And the last, which I would like to show in a series of filaminopathies, is a very interesting case here. We saw several years ago. We genotyped several patients with the new generation sequencing and saw 4 pediatric patients with very severe restrictive cardiomyopathy. All children had quite weak, but still muscle weakness and atrophy, mild CK elevation, and camptodactyly. I will show you later what does it mean. Surprisingly, all these 4 patients with a severe restrictive cardiomyopathy had the same mutation in filamin gene. Here, there is just a demonstration of a huge left atrius, which illustrates a very severe restrictive phenotype, and all these children were below 5 years of age. Here, how does it look? Myopathy, scoliosis, camptodactyly with this very typical 4/5 fingers. And now we know that filaminopathies constitute approximately 1/3 of all restrictive cardiomyopathy cases and approximately half of all restrictive cases if they have a combination with neuromuscle phenotype. First, we published this data in 2017 on these 4 patients, but later on, a lot of males came to our address from all over the world with this very typical neuromuscle restrictive cardiomyopathy phenotype. And now we have published like 13 cases, and they are coming. So this is a very specific neuromuscle and restrictive cardiomyopathy phenotype, which we always have to consider because these patients are very hard to transplant because of their very low weight and some malformations in bone and cytoskeletal as well. Why is it important to consider? Because these 2 genes, lamin gene and filamin gene, are mentioned now in the guidelines, is a very specific points regarding the ICD transplantation. If we look now on the recommendation regarding the ICD implantation in dilated cardiomyopathy, these 2 specific genes, along with several other genes which are of high genetic risk, have a special indication for implantation of ICD. So it's very important for the patients to properly put this diagnosis. The other neuromuscle phenotype could be dystrophinopathies. And this is very classical form, mainly seen in males since it's an X-linked disorder. Very often these patients do not have family history, and they present with very marked LV dilation, and which is very typical for them is a CK elevation. So if we see the CK elevation, we always have to think about neuromuscle phenotype. They're characterized by progressive decrease in left ventricular ejection fraction, decreased CK over the years since they lost muscle mass, and very progressive loss of ambulance. Dystrophin gene is a clearly and very typical gene in this case, and it's very well known how to diagnose. However, one should use all setup of laboratory tests because we can have either exon deletion or point mutation or several exon deletions. So the laboratory tests should be very comprehensive, and not only one of them should be used to proper diagnose dystrophinopathies. The other important point is the heart transplantation in these patients, since respiratory function might be very severely involved. And what is important to consider, the gene therapy is now coming, specific gene therapy. It's not very successful because of the huge gene size, but anyhow, it's important to know that these perspectives exist in these kind of patients. The other type of complex syndromic cardiomyopathies is the rusopathies. And this is in another clinical example on very young infant male with very severe hypertrophic cardiomyopathy diagnosed almost prenatally with a very small left ventricular volume and huge fibrosis. These rusopathies are very well known of syndromic case of hypertrophic cardiomyopathy. And it's considered to be very easy to diagnose because of the facial dysmorphism. However, some of these patients with age, they can lose this dysmorphia. And if they are adult patients, they are not so clearly to see. They always can have myectomy quite often. And the phenotype is quite severe in a combination of hypertrophic and restrictive phenotype. They progressively lose their contractility. And, which is important, we do not have a proper guidelines for the ICD implantations in this very specific patient group. We know several ICD guidelines for the implantation in patients with a hypertrophic cardiomyopathy, which have been just mentioned. But however, it has been shown that in this group of patients, ICD implantation have a very specific indications, and these patients are very often underdiagnosed or underestimated for the ICD implantation. This calculator doesn't work either in children and in adult patients, since it has been shown that it is not proper sensitive for the pediatric group of patients with rusopathies. And the very special guidelines for this type of patients and ICD implantations are very much needed now to follow up these patients. We compared in our cohorts also the frequency of rusopathies and sarcomeric patients among patients with a hypertrophic cardiomyopathy. And so that approximately 1/3 attributes in pediatric group for rusopathies. So this cohort of patients is very important, mainly in pediatric, but also in adult group. And another important point to know is that target therapy is also coming in this very specific patient group. It's not so successful as in a clearly hypertrophic cardiomyopathy yet. There were only several attempts, but anyhow, it is coming, and it's important to know that for this proper group, potential target therapy with inhibitors, kinase inhibitors, is also available. Another clinical case will demonstrate Danon disease. And this is a very important disorder, mainly in young women with no family history and AV blocks and bradycardias. Very often, they do not have a clearly phenotype of Danon disease because it's a very seldom full phenotype manifestation, and mainly revealed as a hypertrophic cardiomyopathy in women with also decreased contractility with involvement of right ventricle and with a tendency to the left ventricular dilations. It used to also mimic myocarditis, and there have been several publications as a Danon disease manifesting as a myocarditis. Anyhow, a very specific mutation has been published in this group, clearly in a combination of myocarditis and Danon disease. It's important to know this diagnosis because it has a special types of red flags. It has very specific signs of manifestation clearly mimicking the myocarditis. It doesn't have a specific indications with ICD calculator and ICD implantations, and it's very much prone to transformation to the dilated phenotype and to the indications for heart transplantation. And another important moment is that AV therapy is now potentially possible for this very specific group of patients, and it's coming, and it's good to know about these options in our patient group. And the very last point I would like to illustrate is an example of Fabry disease, which is quite unexpected also in a group of cardiomyopathies. Here is a case history and case series of several patients who underwent myectomy. And if we look on this data on the echocardiography, they look pretty similar to all patients with the myectomies, with a quite good post-operative follow-up and with a good result of myectomy. What is untypical for this patient, that the fact that after the genotyping, they all ended up with a diagnosis of Fabry disease, but with very mild signs from other organs, with no neurological phenotype and almost no renal phenotype. Why is it important to know? Because for Fabry disease, today, again, we have several indications for the target therapy, and the inflammation, which we see as a basis for the Fabry disease, can be targeted now with either enzyme replacement therapy or with a special chaperone therapy. Enzyme replacement therapy gives the enzyme back, and it is administered intravenously, and chaperone therapy is administered orally. But what is very important is that the earlier you start this therapy, the better is prognosis. And if you start the therapy in patient group which has already hypertrophy of left ventricle, it's quite unsuccessful, and most of these patients progress further. But if you start it earlier in preclinical study or in very low level of hypertrophy, then you succeed very well. So to put the diagnosis early in time is very important in the secondary and syndromic form of cardiomyopathies, not because we genotype, we put the diagnosis and we go to the family screening, but also because for this group of patients, very specific therapy exists, both enzyme replacement therapy and genetic therapy. And to know these options is important to improve the prognosis for all our patients. Thank you very much.
Oh, thanks a lot, Dr. Kosterieva. That was really great. A very difficult, complex topic, but you made it really simple. So we'll keep the question to the end. So it's my turn now to go for the symposium talk, ladies and gentlemen. Please, I remind you to put your questions in the chat box or question answers. We'll deal with those at the end of my talk. So I'm just going to share my screen. So our event tonight is sponsored by BMS, and I'm doing their talk on their behalf. The title of my talk is A New Frontier in the Medical Management of Hypertrophic Cardiomyopathy. I'm sure you've heard this title name before. So I'll just go quickly. So Dr. Sam Ghalib, fantastic talk, told you that hypertrophic cardiomyopathy is really common, and we are really underdiagnosed it. You probably diagnose 1 out of 6 or 7 patients. We need to diagnose more, particularly now that we have treatment. I mean, first, obviously, risk reduction, the people who need ICD have to put it in, but also we have medical management for the obstructive type, which is constitute 2/3 of the hypertrophic cardiomyopathy. The old guidelines up till the last couple of years tell us always go about give beta blockers, titrate maximum dose. Then if it doesn't work, try calcium channel blocker. These you have to avoid if the patient brain is more than 100, like the case that Dr. Ghalib presented, because they have a vasodilatory element, these calcium channel blockers, and maybe danger in actually class 3. Should not use them for those people, particular people. And then you can move on to pyramide or septal reduction therapy. As Dr. Hussam Ghalib mentioned, that has to be done in an experienced center, and there are few them around. So a lot of centers do 1 or 2, 3, 4, 5 cases a year, and they claim they are. And then I'll come to the reason why, although Dr. Hussam already alluded to. Problem with drug therapy, not always very effective. There are a lot of side effects. You don't alter the course of the disease. No real randomized trial. Septal reduction therapy, it works. There's no doubt about it. And you can say it does change the course of the disease because you eliminate the obstruction forever if it works in the right place. Because if you don't do it in the right place, you get more complication. You're more likely even to die. Pacemaker with septal alcohol, stroke, bleeding. So risk is higher. And there are very strict criteria, as Dr. Hussam Ghalib mentioned to you, about for centers to do them, and therefore there are not many around. So really, we are still stuck in places, where you don't have these centers, where people actually preference do not want to have the operation. There's unmet medical need. And here comes the fantastic, really group of drugs, the cardiomyopathy inhibitors. Dr. Ghalib already told us how this works. Just to a reminder, so in people with hypertrophic cardiomyopathy, what they have in their sarcomere, their myosin to actin bridges are overactive. So we normally have a lot of what call bridges or heads of myosin that attach themselves to the myosin on either side and really pull them around to contract. But normally only 40 to 50% are active. So there are only 40 or 50% of these bridges are really active or connecting. The rest are actually calm, and that's what leads to a really nice contractility and effective relaxation. In hypertrophic cardiomyopathy, you have loads. You have up to 80% of these bridges are really stuck, connected to connecting between the myosin and actin. And this leads to really unnecessary hypercontractility and difficulty to relax. And that's the problem. So now we have these agents. Mavacamten is the first who came and has really approved. We'll come to that in a minute. But it is, in those who don't know, it actually is not a dangerous drug. It's not like it leads to damage to the myocardium, because people fear about reduction in ejection fraction, think this is going to damage your myocardium forever. I will never prescribe it, I will never have it. It actually is a reversible agent. As soon as when you stop it, the effect goes away. So it is a reversible inhibitor of the myosin. So what it does reverse the situation from having too many bridges between the myosin and actin, the 80 to 90% that keep pulling and not relaxing, to reduce them to the number that everybody has, to the 40, 50% contractility bridges that leads to a better, more ease, nice contractility and better relaxation. You can see the principle is very logical, and it really just reverses you from abnormal to normal situation. And if you do echocardiogram for a patient before, as Dr. Hussam Ghalib demonstrated to you, before and after giving mavacamten, you see a reduction in the accelerated flow that indicate LVOT obstruction, reduction in the MR, and more importantly, significant reduction in the LVOT gradient. And if you do an MRI on these people before and after, you see reduction in left ventricular mass, so that thickness becomes less. And also the left ventricular side, which basically dilates because of the diastolic function, high left ventricular filling pressure, it becomes smaller. So the mavacamten has what they call actually a program, as a lot of drugs when they come into activity, go through a research program, phase 1, phase 2, phase 3. And I'm just going to talk about the phase 3 trials, the Explorer hypertrophic cardiomyopathy trial, and the Valor hypertrophic cardiomyopathy trial, and the extended long-term extension of the Explorer from mavacamten. And this I'm not going to talk about because that's an ongoing trial, believe it or not, in non-obstructive cardiomyopathy, enrolling 420 patients, but this is ongoing trial, so we don't have really much data on it. So the Explorer hypertrophic cardiomyopathy is the largest hypertrophic cardiomyopathy enrolling 251 patients across 13 countries in 68 centers. So, as big as you can get it with this relatively uncommon condition. And what it looked, basically, we're not looking to people who are asymptomatic. We need to improve the symptoms. So look at people who have a gradient, either resting or exercise-induced or Valsalva-induced, of more than 50, and they have to be symptomatic, class 2 or class 3. And they randomize them 1-to-1 to either having oral mavacamten or placebo, with a step 2 steps titration at 8 weeks and 14 weeks, and follow up for 30 weeks. A majority were white. You can criticize that. Most patients were on all patients have either on beta blocker and or calcium channel blockers. People who had diazepamide in this trial were excluded. All were symptomatic. They all had an NT-proBNP raise. And they all had genetic testing, although most of it, according to this table, were negative. And the composite endpoint, because we want to improve symptoms, so looking at the symptomatic improvement judged or assessed by patient-reported symptom in the NIHA class or questionnaire, and also by improvement in the CBET test, by improvement in the peak oxygen uptake. So these are the primary endpoint. The secondary endpoint consists of this list. It change in the exercise-induced LVOT obstruction, gradient obstruction, the peak oxygen consumption, the change in the NIHA class, the patient-reported symptom in the consistency cardiomyopathy questionnaire, or the HOCM-specific hypertrophic cardiomyopathy self-reported questionnaire. And guess what? The trial meets all primary and secondary endpoints with 30 weeks, 37% in the patient in the mavacamten, met the primary endpoint, which as I mentioned before, compared to only 17% in the placebo. And the changing gradient was really dramatic. There were 47 millimeter average reduction in the LVT gradient by mavacamten compared to only 10% in the placebo. And 75% of patients on the mavacamten achieved a gradient less than 50, and 50% achieved gradient even less than 30, and 30% achieved not only a reduction of gradient to less than 30, but also NIHA class 1, completely asymptomatic and almost cure, symptom completely, gradient gone, the symptoms gone. And on the CBET testing, there was an increase in peak oxygen uptake of 1.4 ml per kg per minute compared to nothing in the placebo group. And the patient report symptom of the NIHA class, there were at least 65% of patients of the mavacamten has at least one improvement in NIHA class, i.e. from NIHA 2 to NIHA 1 or NIHA 3 to NIHA 2, at least one, if not more, compared to only 31% in the placebo. And patient-reported outcome in the theme of questionnaire, where obviously there was significant difference between the placebo and the mavacamten group. So it sounds all good. They change the gradient. Can this agent change the natural history of the disease? Is it a disease-modifying? Does it have disease-modifying benefit? This was not really part of the of the purpose of doing the study or the outcome, but it were signals, which I will go through in a minute. There was significant reduction in the cardiac biomarker. NT-proBNP significantly reduced. The troponin was significant. There was 80% reduction in NT-proBNP. This is, what is this? Is it interesting? What's this? Is it SGLT2 inhibitor? It's doing this. And it's actually reducing your troponin. It's doing something. It's causing remodeling. Clearly, there are markers. Not only the biomarker, but also when you look at the left ventricular mass index, it reduced. Left atrial volume index reduced. If you look at the markers of diastolic function, there was significant reduction in your E prime. There's significant reduction in E to E prime ratio. This drug is doing something. There are ongoing trials, as I said, even the non-obstructive. This may not only obstruct to me, it may be a drug for HFpEF, I don't know. There was actually in 80% of patients, the SAM is gone. The the circulatory motion that Dr. Samuel demonstrated to you is gone in 80% of patients on mavacamten. There's actually complete resolution of the MR, 9% of patients on mavacamten. Amazing. Wow, what's the problem then? This damages the heart. It will damage your myocardium. It will cause you, change you from HFpEF to HFrEF. No, it does not really. But this drug is very well tolerated, and the safety profile very similar to placebo. 97% of patients completed their 30-week trial. Only 9 patients, 7 of them on the mavacamten, which is 5%, experienced transient reduction in the ejection fraction. Once you stop temporary and you start with smaller dose, it reverses. So there's no worry about that. Is it safe? What about long term? This is 30 weeks. What about if I keep my patient on longer? Is it worrying? Is the effect sustained? Is the safety still okay? As I said before, this was looked into the mavacamten long-term extension, and basically it looks at the efficacy and safety of mavacamten in obstructive cardiomyopathy. It's basically the extension of the Explorer hypertrophic cardiomyopathy. And what they did at the end of the study, patient re-enrolled after 8 weeks washout, so they start them again 8 weeks later. And this is still ongoing, but the 3.5-year data was published and presented not long ago. And what it shows really, and not surprisingly, that the improvement in the NIHA class comes and sustained, and the patient-reported symptom of improvement or less breathlessness also sustained for up to 180 weeks, 3.5 years down the line. Patient still remains well. The NIHA class patient basically feeling well, NIHA class better, and not symptomatic. And the LVO2 gradient, which drops initially in the first few weeks, continue to remain down, whether it is resting or Valsalva induced. And the NT-proBNP, which is related to earlier, which comes down rapidly. If you stay on the mavacamten, your NT-proBNP continue to be low. And your diastolic parameter, your left atrial ventricular, left atrial volume index, and the E prime ratio comes down and stay down. So the effect sustained up to now 3.5 years, and your ejection fraction does not drop further. You have this initial drop that we mentioned, which occurred during the titration period, but once you stabilize on your dose that suits you to keep your gradient down, your ejection fraction remains stable, and 95% of the patient remains on this long-term extension trial. So what about those patients that were really the one that Dr. Hussam presented earlier on, who actually eligible, not only eligible, but referred for septal reduction therapy because they are really quite symptomatic despite all the medical therapy. So this was looked into the trial called Valor hypertrophic cardiomyopathy, which is done in the States. And these patients, all the patients were already referred, so were symptomatic, so class now, not 1 or 2 or 3 as the AL Explorer. These are class 3 or 4. They're quite symptomatic. They already actually, with high gradient, already been referred so for septal reduction. So 126 patients. At the time of the referral, these are done in actually, excellent centers as far as septal reduction. But at the time of the referral, they were offered to go into this trial where they said, okay, hang on a second. Do you want to try this medication? Do you want to be randomized to this trial? We'll give you either a placebo or the mavacamten. And we just follow it for 16 weeks. You're not going to wait for forever. And at the end of 16 weeks, we'll see. Are you still requiring septal reduction based on your symptom, based on your gradient, or not? And after that, and we'll come to that later, after the 16 weeks, patients were offered, because I will tell you the success, patients were offered to even the one with the placebo to take mavacamten and continue with the follow-up. So if you see the brown mavacamten versus placebo at 16 weeks, but after the 16 weeks, even the placebo group, we've gone into mavacamten because I'll tell you, 95% of patients wanted to enroll into the longer follow-up for 32 and then even ongoing follow-up extension, long-term extension. So again, the primary endpoint, as we said, patients were already referred to have septal reduction. At the 60 weeks, are they still needing that based on their symptom, based on their gradient, based on the criteria for which we are referred to or not? That was the primary. The secondary, as the explorer, looking at the change in the gradient, the NIHA class, patient symptom, reported symptoms, and the cardiac markers. So what happened? So 82% of the patient already referred originally for surgery because class 3 or 4, when they had the mavacamten, no longer required, no longer in need. All the criteria, everything changed. The symptoms gone, the gradient has gone down. They're no longer needing surgery. And 95% of this patient, even in the even the placebo went on and joined to continue with the study going with mavacamten. And there was up to 40% reduction in the peak LVOT gradient. And there was significant improvement in the NIHA class. You'll not be surprised on the mavacamten group. 63% of the mavacamten group had improved at least one NIHA class improvement. And when they followed them for 32 weeks, now both groups become one group. 88% of the both treatment group now become one, because all become treatment group, no longer meet the guidelines criteria for septal reduction. Can you believe it? 80%, 90% were not. And now we have even a longer follow-up for up to 56 weeks, and the benefit sustained, both in the term of symptoms, NIHA class, gradient, they improved and sustained for up to 56 weeks. These people who are just 56 weeks ago were referred for septal reduction therapy. So the guidelines have to change. So the 2023 obeying guidelines, yes, kept talking about beta blocker and psilocybin and diazepamide, but now giving cardiac myosin inhibitors, specifically mavacamten class 2A recommendation to be used. And the American of this year, having had the results of the here's the trial. The name is going to be mavacamten. Now they gave the cardiomyopathy inhibitor class 1 recommendation, so it became class 1 recommendation. It still says they have to use it in symptomatic, of course, symptomatic patient after failing the beta blocker and the other therapy. And I did not mention the Valor trial include the innovation on the diazepamide. We'll wait for the time where actually this becomes even a first line, not second, third line. But still, it's the class 1 recommendation, which means that you should consider the patient. So patient selection, maybe we'll go that in discussion. Dr. Hussam Ghaba, with his experience, maybe tell us about the RIMS. But I'm just simplifying it. So basically, anyone who's symptomatic, class 1 to 2, 3, but also now class 4 based on the Valor trial, who does not respond to the beta blocker and calcium channel blockers with a grade more than 50. Obviously, not for ejection fraction is low. Should not give the triple therapy, so we have to give more with beta blockers or calcium channel blocker, not the triple. And if the ejection fraction, you have to close follow-up, and the ejection fraction drops to less than 50. You temporarily stop and start with a smaller dose later on. So just to finish off, so mavacamten is the first and the only cardiac myosin inhibitor approved. It's been approved by the FDA since 2022 for symptomatic patient with class 2-3 obstructive cardiomyopathy. I've shown you it's superior to placebo, improvement, not symptoms, exercise tolerance, quality of life, LVOT gradient, cardiac echo markers, and placebo. There may be transit reduction in 5% of patients if their ejection fraction, which is reversible. It's been approved by the FDA since 2022, and it's class 1 recommendation. And that's it. Thank you. So now being the moderator, so we are open the questions. I think we got some questions in the group. I'll just go by them and then put questions of my own. So maybe this all the cardiomyopathy inhibitor, I'll ask them to Dr. Ghalib. So they said, the question says, Dr. Ghalib, between mavacamten and avicamten, which one you would prefer to start with?
Agents as it is more agents being available for this condition. And these selective cardiac myosin inhibitors have really rejuvenated the field of heart failure and directed therapy and untargeted therapy, which is where the entire field will move from now on, because these are really selective inhibitors of the cardiac myosin, so they don't really interact with myosin in the skeletal muscle or elsewhere. And while there are no head-to-head trials of both, it's good to have multiple options, as we know. There's only one sacubitril/valsartan, but it's good to have multiple of these agents. As of right now, as you had stated, mavacamten is the only FDA-approved agent, and that is currently available in most markets. In my practice, I do follow the stringent Explorer HCM and Valor HCM criteria, as you had just stated in the last slide, because this would be an agent that these patients will be on lifelong. And some of these patients are very young. So it's important to make sure that they meet the inclusion criteria of having a persistent gradient above 50 in spite of one or two agents. And I do go on 2 agents and sometimes on 3. Prior to initiation on this medication, and I do follow the REMS. But once aficamten, gets the FDA approval, right now it's got the breakthrough approval by the FDA. But once it gets the full approval and it becomes available in the market, then it'll be good because this can reach more patients as well. But mavacamten, as you had just showed, has a noticeable and sustainable improvement in symptoms, in gradient, and in avoidance of SRT. So as of right now, for patients who do require it, that would be the agent to use. I'm not sure if this answers the question or if Dr. Anna or yourself want to expand upon it.
No, not really. I said it's not one or the other. Yes, it's great to have a drug that works so efficiently, really. But it's fine. I mean, okay, we say 80-90%, but there are the small group of non-responders. So is there any sort of criteria? Can we tell this may or may not respond? Sam?
Not that has been, I mean, that's being looked at. The subgroups of these patients in these trials are being looked at. And as we get more and more real world data, as I showed of these patients, there is some, the Italians have published their experience of within a center, HCM center with obstruction, only about 2/3 of the patients met the criteria for the Valor HCM. Real world data becomes the important thing now as this drug is being moved in the markets and being utilized. What I had showed you initially is that the interactions for HCM between the myosin and actin aren't really all in that thick filament segment that I had shown. And the thought process is that these non-responders may have mutations in other genes, or the HFpEF phenotype is more substantial than the usual obstructive physiology. But that's why it's important as we get more and more of these selective cardiac myosin inhibitors that target different parts of the interaction, we may be able to move between drugs for non-responders, as you had mentioned.
Dr. Kosteriv, just talking about the genes in this specific agent, the genetic test was done in all of them, and my reading is that actually the majority were negative. But was there? I mean, I could not actually go too deep into the trial. Was genes people actually were gene positive, gene negative, more responders, and can we use genetic to even select the patient who actually respond?
Shall I answer? Yeah.
Yeah.
Yeah, okay, I can try maybe to comment. Since in this year, a very interesting paper was published regarding the genetics as a background for their response for myosin inhibitors. And unexpectedly, in a long-term procedure, sarcomeric carrier mutations responded actually worse compared to the non-sarcomeric. But the reason was probably that in the very short, in the very beginning of the treatment, they were very quick in response. And therefore, they did not titrate the dose further to the maximum tolerated. So what we can say right now is the only fact that sarcomeric protein mutations carrier, they quicker respond and they drop the gradient quicker. Therefore, you have to consider this in terms of dose titration. I think we are just in the very, very beginning of knowing the combinations and where the genotype really influence the long-term response and the dosage in use. But definitely, since the drug targets the myosin-actin interactions, and half of these patients do have the pathology in myosin-actin interactions, it might influence somehow. But how it is realized, we don't know yet. We just observe. I hope maybe in 2-3 years, we will know this information better.
That's great, thank you. Hussam,
Dr. Mohammed, if I may just comment real quick, what we do notice is that the patients who have positive mutations rarely have obstruction, and the patients who have obstruction rarely have sarcomeric mutations. It's a very interesting divide in these patients, and I'm always surprised when a patient has a sarcomeric mutation and has obstruction. I go in and look at their genetic testing in detail to make sure that it is one of the most pathogenic. But it's interestingly, the patients with the genetic mutations have the reverse curvature or the sigmoid septum phenotype, with a septum up to 3.5-4 centimeters, but no LVOT obstruction. So it's a very interesting phenomenon that we see, which carries on to what Dr. Anna was saying.
Very interesting. Sam, this is a question from the audience. Probably I'll pass it to you. It says here, 19 years old male, after 5 months on mavacamten 5 milligram therapy, CK elevated up to 12,000, CKMB 60, LDH 255, AST up to 182, ALT 64, myoglobin 187, ejection fraction remains above 55%, LVOT gradient more than 30. What we have to do, stop mavacamten therapy? That's the question in the group.
That's an interesting question, and I'll have Dr. Anna also opine on it if she wants to. It sounds like this is a case of rhabdomyolysis or muscle breakdown from in this patient. Now, the timing makes you think that mavacamten was really the causative agent, but if we go through a process of stopping mavacamten for a very small drop in ejection fraction, I think this would be even more reason to hold the medication and look for any reversibility, as this is a reversible condition. You would want to reconsider the diagnosis again and make sure that we don't have some of the medical problems that Dr. Anna had presented on, which can be a masquerader of hypertrophic obstructive cardiomyopathy. But definitely, any agent, when it concomitantly causes an extracardiac significant condition, needs to be withheld and its reinitiation be closely considered.
Yeah, probably just another point, just to add, maybe if there's check what patient other medication been on or added on, the interaction with the CYB tablets. Okay, I've got more questions. Dr. Kosteriva, really, the genetic always, to be honest, puzzles me personally. And when we see heart failure or whatever, we just do standard exclude coronary disease, do MRI. Now we think more about amyloidosis, maybe a little bit about Fabry disease. what tips you can give to general cardiologist, general physician about red flags of this patient may have a genetic test that we could do something, we can treat that. So what are the red flags and what tests we should do?
I think we can start from a couple of very simple and totally available tests, like a total CK and IST and ILT. That might be quite enough for the very beginning, because if you see the patient with a high aspartate transpinase elevation, you do not have to think immediately about hepatitis or liver conditions. You might think about cell lysis and muscle damage. And the same is very sensitive for CK, especially if you see it in males. Just take it as a rule that in every patient with any type of cardiomyopathies, look for CK and other enzymes, as well as look for the neurological complications. Just think about it and you might see it.
Great. Question for you, Dr. Ghalib, says about your patient. Did you try your patient with, I think they try a patient with beta blocker, calcium blocker before mavacamten, or how would you, regarding your case, but then you talk about mavacamten, although your patient went for a septal reduction therapy. I think the question, would you started beta blocker or calcium blocker?
I think the question is why mavacamten was not offered to this patient at the time. This case preceded the arrival of mavacamten in our market, but this would have been the ideal patient to try it on. Few cases where you would initiate it but still consider septal reduction therapies are when patients have concomitant mitral valve or left ventricular pathology that is playing a role in the symptoms. So if a patient has severe mitral regurgitation that is not all related to SAM, which we do see in some of these patients, and they need a mitral valve repair or a mitral valve replacement, or there's been damage to the aortic valve because of a subaortic membrane, then in that case, the thought process in mavacamten isn't really going to resolve all of those, but it still would be a cornerstone of the therapy. In this situation, it was just a timing issue. Mavacamten had not become available in the market. But this is why I said it's not too many patients in my center that follow for HCM that actually qualify for mavacamten as of right now. And that may change as we get more, once these medications make it to the market, there becomes an interest and then referrals increase, and we may see a change in that. But I see a less than 8% of the patients in my clinic actually qualify for mavacamten as per the very strict Valor HCM trial. But to go back to the genetic question that you asked, if you take a good family history for a patient and you do a 3-generation history, things come up that indicate that this is there's a genetic component to these patients, especially if you look for the extracardiac manifestations of these conditions as well. But if you take a 3-generational family history and that's negative, that pretty much excludes most of the genetic cardiomyopathies that you think about. And here we live in a community where there's close-knit families and they tend to know what happened to their families. So I would say just focus on the history and the physical prior to engaging in genetic testing, because it comes with an added cost.
Question says, is it appropriate to prescribe mavacamten for apical cardiomyopathy without obstruction or mixed apical plus mid-ventricular obstruction? I would say, as of now, we cannot. I'm not sure about the mixed. I'll leave that. I'll ask you, Hassam, to answer that. But for now, we don't have the evidence. Although I think theoretically, now there are trials going on for even non-obstructive, but for now, not. Mixed plus mid cavity. Would you prescribe it? No, Dr. Ghalib, mid cavity obstruction.
So that's being studied. So mavacamten is being studied in the apical or the non-LVOT phenotype of HCM, and we're looking for those trials. Mechanistically, it should be a positive trial. but we do have to wait for those results. Most of the patients with apical hypertrophic cardiomyopathy do not present with obstructive symptoms, but the mid-ventricular ones do. So I would, I'm by the books, so I will await those trials. I will let Dr. Anna opine as well. But mechanistically, it should work.
Yeah, we had a recent case of mid-cavity obstruction with really high gradient, but again, it doesn't qualify. Dr. Christina, please feel free to comment if you feel you need to. Question says, any interesting drug-to-drug interaction with I presume CMI? Anything special? I think they are metabolized by the CBY system. So, the antifungal, the anti-HIV. They said also the hormonal oral contraceptives should not be combined with. That's what I know from my reading, but I'm sure Dr. Ali will probably have more comment.
No, you nailed it. You mentioned that it's mainly looking for metabolizers, which may augment the reduction in LVEF that was seen with mavacamten. But there are other non-CYP associated medications that we're very careful with, particularly PPIs, which are very commonly used by these patients. And verapamil, believe it or not, is another one that is commonly looked at. So if you want to boost the medications, or patients who don't have access to the 10 milligram, if you want to go up that route, or if patients are having a drop in ejection fraction, some of the centers in the United States are being very genius with their approaches of how to adjust the medications. It's kind of like our transplant approach. But yeah, make sure the patient is not a hyper metabolizer or a low metabolizer. Look at your PPIs and consider reducing the dose of verapamil. And obviously get an echocardiogram with every change in medication and reassess. Dr. Anna, anything to add on top of that?
No, I think it's quite right. Since we do not have a very big experience in drug-drug interactions with these kind of drugs, I think we just have to be very careful and go step by step. A bit more careful compared to what we do when we prescribe beta blockers or calcium antagonists. Just keep your eye on, let's say.
Yeah, I'm just going to go back to the hypertrophic cardiomyopathy, with risk reduction. We just had a case last week for a patient in the 40 presented with heart failure, but had clear apical outcome, and you confirmed by the MRI with a very small apical aneurysm. We were debating the indication for ICD, ICD, whether you get the European, when we're talking about from the American. What approach do you use? I mean, you mentioned something that I was not aware of for risk stratification. I just want simple model that everybody agree with, because if you may see the same patient, if you look at the European and say will not, you look at the American say will, or vice versa.
Yeah, this is a common question that comes up, the apical hypertrophs and how to risk stratify their sudden cardiac death. The guidelines themselves don't give it a class 1 recommendation I'm talking about the American, to implant an ICD, but this is considered a higher risk subpopulation where the fibrosis potentially has caused significant to the point of an aneurysm and the increased risk of sudden cardiac death. It's all based on one very large cohort of follow-up, that albeit it was follow-up in North America, where they did notice that patients with apical aneurysms had an increased risk of sudden cardiac death. Our approach here has been to implant ICDs in these patients if we have that after a careful discussion with the patient. Every ICD decision has to be a shared decision, because these patients have to live with the device, get the generator changes every 10 years, deal with any inappropriate ICD shocks. So it's not it's not as prescriptive as an ICD in an ischemic cardiomyopathy, for instance. So it's a discussion with them. And if it's a patient who is risk averse, then we do implant them. Now, what has happened with these implants? None of them have had any ICD shocks for appropriate shocks. So it tells you when you extrapolate data from one part of the world, from one trial, and you bring it to a different population, you may not be treating the actual right phenotype or subtype of the patients. But patients who have high risk jobs or are very risk averse, and they say, if the risk is even 1% higher, I want to go for it. We've implanted them. Now it helps when they have had some NSVT on a Holter monitor or have a high risk based on the calculation otherwise. But this is a challenging situation to be in, for sure.
Great, thank you. Dr. Kosteriba, question to you, I think, from the audience. Say, does mavacamten work with genotype negative and phenotype positive patient with obstructive hypertrophic cardiomyopathy? Maybe to both of you, but let's start with Anna, please.
Yeah, I think we have already discussed it, because in a cohort of patients which was recently analyzed, both genotype sarcomeric positive, and then it's a question, what do we call genotype positive? Do we mean only genotype sarcomeric positive, or we include also all those mutations which are not in sarcomeric genes, but still proven to be related to hypertrophic cardiomyopathy, like, for example, filamin C mutation, TREM mutation, other mutations. What we know right now that for both these groups, mavacamten works, and in sarcomeric groups, it gives quicker response, which doesn't mean better response or deeper response or longer response, but simply quicker response. I think we need more and more collecting data, and I'm pretty sure that they're coming very soon.
Any comment, Hassan?
Nope. Very succinctly put. Nothing to add.
I agree. There was a question actually at the beginning which I missed. It says, patient presented with acute heart failure, what drugs should be avoided? Patient with hypertrophic cardiomyopathy, what drugs would you avoid, Dr. Hall? So known hypertrophic cardiomyopathy coming with heart failure, any drugs to avoid?
You need the echo. If there's been a substantial drop in the EF, you know the one. More importantly, calcium channel blockers are also contraindicated in low ejection fraction as well. So you would look to see if the patient's newly on mavacamten, or if they are also on a if there's a drop in ejection fraction, if the calcium channel blocker is playing a role. Now, if there's been no drop in ejection fraction and they come with heart failure, this can be a HFpEF manifestation of hypertrophic cardiomyopathy. Which, in spite of the drop in NT-proBNP and all the things that we had shown, it does happen. These patients do have diastolic dysfunction and can develop heart failure, in which case you treat it like any HFpEF exacerbation with loop diuretics and making sure all the other risk factors are controlled. But if the ejection fraction dropped, look at your mavacamten and make sure, like you said, Dr. Al-Harari, the patient hadn't recently been put on a medication that boosts the levels or something like that.
And maybe just add to that, I'm not sure that covered the question or not, to somebody with really quite significant obstructive cardiomyopathy coming with heart failure, make sure they're not really that tachycardic, make sure they are not, don't give them vasodilators, and don't really overhydrate them. Sometimes you treat them much with some fluid and reducing the heart rate because you make the obstruction worse. So it depends on what the scenario, obviously, the echo one. So that's something just to keep in mind. Some just mentioned obviously about the center of excellence, and you showed data that show that each patient treated with the center of excellence do much better than others. I mean, would you see that all hypertrophic cardiomyopathy should be seen in one center, or hub and spoke, or how do you see the model, say in UAE?
No, I don't think that would be a good model, appropriate model for multiple reasons. One is, very simply geographically, these patients don't have to come for their follow-up, appointments, long distances. Two, it is a very common condition, so it can easily overwhelm one center. And thirdly, there are a lot of really good cardiology centers throughout this country. For instance, Dr. Anna will talk about how, Russia's, the largest country in the world. So having one center of excellence is not really going to work out. The model that I would propose is close collaboration, close communication, a direct line. And once the patients get to a point of being considered for either these selective cardiac myosin inhibitors and/or septal reduction therapy, or the patient is slipping away into advanced heart failure, just a discussion, so that I would know that if Dr. Al-Harari calls me about an HCM, he's already looked into all the A, B, C, D, E's of these patients. And that he's really referring a patient to me for, this is it. They need a septal reduction therapy, or they need a transplant, or need an LVAD, or the ICD decision isn't really as clear cut, as we had mentioned, and so on and so forth. And these sort of educational programs really do help with those. If you need a septal reduction therapy, it shouldn't really be any cardiac surgeon doing it. It should be somebody who does it frequently, knows how to deal with the complications, and it's really an OR team. The anesthesia is different. There's a echocardiographer basically who focuses on this condition in the OR the whole time, making sure that, they're not taking too much of the septum and they're not injecting too much alcohol, and so on and so forth. And naturally, if these patients are advanced and they need a transplant or an LVAD, it needs to be a center that knows how to LVAD these patients or manage their hypertension, their pulmonary hypertension. So not all patients, close collaboration, close communication. And I frequently refer patients back. It could be a one-time consultation where you lay the framework of how the management will go, and then you'll say you're going to return back to your primary HCM center, and we will continue to discuss your case. And should you need any further therapy, then you've already been established in our center. Dr. Anna, maybe if you want to expand upon that.
Yeah, I completely agree that, of course, with such a common pathology, and it goes not only for HCM, it goes for other types of cardiomyopathies as well, we can have just one center or even two centers. But I still agree that we do need to have centers of excellence, and maybe not for routine checkup, because, for example, if the patient is genotyped, has a diagnosis and has a treatment, it is recommended to have a routine screening once in 2 years, for example, or every year, depending on the age. And all these routine screenings can be definitely done on site, on the place where do they live, if they include only, for example, echocardiography, Holter monitoring, and other things. But for any other important decisions, maybe not for dose change, but for important decisions regarding antiarrhythmic drugs, for example, or septal reduction therapy, or ICD implantation, or, for example, if the ejection fraction drops, those patients have to be sent to the reference center, because it's not only dealing with a dosing or ICD implantation. It's good to have also the surgeon in the team. And it's also good to have, for example, pediatric team in this community to discuss all this together, because we have to consider that sometimes we take pediatric patients and very often they became adult patients. So the teamwork is very important, but of course you can have 1 or 2 or 3 teams. You need to have several teams, and education in this case is very important.
Perfect. We're running out of time. It was a really great event, and I thought it was going to be a bit odd combination, but a really genetic cardiomyopathy, but it's really, I think, worked very well, and I've really learned a lot. And I'm sure the audience learned a lot about the cardiomyopathy, hypertrophic, the genetic rules, genetic classifications, and how to, to risk stratify your patient, the new treatment. It was really eye-opener for me. I'll give the speaker a couple of minutes just to closing remarks, and then we'll close up. Audience, you will have a link to fill your feedback to get the CMEs. So ladies first. Dr. Anna, you want to close?
Thank you. It's really a pleasure for me to discuss this topic. because for many, many years, we are in the field of genetics in cardiology. And for many, many years, we have to be very disappointed by the fact that we cannot use this genetic knowledge for such extent as we would like to use in terms of helping our patients. It's very curious for us to know the genetics, but there were so few we could really do with this knowledge. And now with the coming of this target drug therapy, and it's not only mavacamten, it's also those which I have mentioned in secondary cardiomyopathies. Now you can really see the real idea of understanding the molecular pathogenesis of this disorder, and it can give a lot of benefit to the molecular treatment of our patients.
Thank you. It was great having you, really. Dr. Samghar, closing remarks, please.
It was an absolute pleasure to be part of this event with Dr. Anna and with Dr. Mohammed. I just echo what you guys said. It was such a learning experience for me to learn from you too, and to go over this. You know, we used to be the unexciting child, or the in the family. You know, it's always about LVADs and transplants, but just like we saw with amyloidosis, once therapies become available, suddenly the field becomes very available, and suddenly people want to jump onto it. So this is a very exciting, you know, part of genetic cardiomyopathies and the journey. You know, there's going to be more targeted therapies. We're hoping there could be gene therapies in the future as well, and trials for that. You know, anybody who stayed late to listen to this, this is going to be a field that's continuing to progress. I thank again the organizers for the invitation.
Thank you. Really, there's nothing for me to add other than thank you both, and thanks the sponsors, BMS, thanks Rania and the ICON team, and have a good evening. Thank you. Goodbye.
Thank you. Bye-bye.